All right, we're going to go ahead and get started this evening. Tonight, we'll be covering chapters 9 and 10 of the EMT B curriculum. We'll be talking about the team approach and how important it is to work as a team. It's hard being the one-man band, and it's even harder when there's so many situations requiring more hands than you actually have. So learning how to work as a team, even with people you don't like, is an important factor of being a successful EMT, paramedic, firefighter, police officer, whatever type of first responder you want to be. I have worked 24-hour shifts with people I hate. Hate's a strong word. I loathe them entirely. But that don't mean they ever knew anything about it. I still treated them with respect. I still treated them with professionalism. You can work with people that you don't like. That is one of the gambits of kind of working in EMS and fire and police and stuff, is that we have such a huge generational gap. I remember being a young EMS manager, and I was like, man, I got to kind of manage this guy a little bit different than this guy, because this guy's a boomer and this guy's a millennial, and this dude's over here in that Tide Pod eating generation. So they all had different nuances and a little bit of different ethical things going on there. But the main thing is, can they work together? Can we work as a unit on scene? And I found that truly dedicated professionals can do that without a hitch. Sometimes it means swallowing our ego, swallowing our pride, and just doing the job, remembering that the patient doesn't give a crap what patch you have, what your level of certification is. You can be a rocket scientist, doctor or something, and the patient will not care. So it is really, really about the patient on scene. So I'm gonna go ahead and get started and share my screen here. We're gonna start with the team approach. All right, let me move this guy out of the way so we can get cooking here. All right, so when I say the team approach, I want to again remind you that you can't be the one-man band. As strong as I am, there have been patients I couldn't move. As fast as I am, there's been people that could get there quicker. We have to work as a unit, and we have to understand that it's not about us, it's about our patients. So we're going to apply this knowledge to help you learn how to pass the 2021 EMT B curriculum. So first thing you need to know is you're a critical member of the healthcare team. It isn't just emergency medical EMT, it's emergency medical services. EMS is a unit. We are about community. So it takes EMTs and paramedics and firefighters and first responders and police officers, the occasional EMR, it takes the volunteers, it takes the hospital staff, it takes us working together as a unit to make this kind of whole thing work together. I will say that even as a paramedic, I take pride in that, but I would say that EMTs are definitely the backbone of our industry, because there's just 3 times more of you guys. And without you, it would not work together. I have worked with other paramedics, and it's a lot harder to work with other paramedics because you can't have 2 chiefs on the same truck. Now, sometimes it's nice to go back and forth and trade out on calls sometimes, but having a good, strong EMT there that can remind you of the basics is what really saves lives. I don't really want to say that because it's so cliche at this point, but paramedics save lives, EMTs save paramedic lives. Well, sometimes paramedics do get tunnel vision, and sometimes it takes a good BLS provider to remind them to do the simple things first. Just because you can do a skill don't mean you have to. Let's take the congestive heart failure patient. That left ventricle is trying to pump out, but it's diseased and weak. So the blood will back up into the lungs. A lot of times I fix these patients by sitting them up high and putting them on a cannula, and they do really well with just say high Fowlers and that. I don't have to throw CPAP and all this other advanced, medical stuff that could be quite invasive on them if I just remember the basics. The National Registry, paramedic test is actually about 80% EMT B curriculum stuff. Why? Because good paramedics know the basics first. So if any of you are deciding that one day you want to be more than an EMT B and go to a paramedic land or nurse land or become a doctor, a PA, or a drug dealer, or whatever your goals in life are, you are more than welcome to remember that the basics is what save lives. Let's take CPR, for instance. I mean, as a paramedic, I can do a bunch of cool things. I can intubate, I can cardiovert, I can come out here with all these fancy cardiac drugs, but if the CPR ain't perfect, if the CPR is not perfect, I will not save anybody who's in a cardiac arrest situation. And CPR is a BLS basics type of skill. So Let's not forget our humble beginnings here. So a key goal of the EMS agenda of 2050 is EMS systems are inherently safe. We want to minimize exposure to injury, infections, illness, and stress, have a culture of safety and just culture. So there is kind of a little epidemic in EMS with back injuries, with injuries in altogether. Your discussion post this week was, should EMS be wearing body armor? Should they be carrying firearms? I'll go ahead and give my opinion on that right now. EMS should not carry firearms. I have done this a long time. And one of the reasons we have been so successful at what we do is because the public trusts us. That public trust is part of a sacred trust that is a social contract. And that social contract has saved my life many a time. We do not need to carry, because there would be somebody that would get afraid and they would hurt somebody, and then everybody's not trusting EMS, EMTs, and paramedics. We do not want to lose the public's trust. We do not want to lose the public's trust because somebody would overreact. There have been times that a gun was pulled on me. I was joking with one of my AFD paramedic students today. He works for East Point Fire. I was telling him I was working at Grady, and this one night, and this guy who's in East Point, Georgia, and of course this guy pulls a gun on me and my partner. Y'all better save my grandmama. You better save her. Now grandmama was dead, like rigor mortis to set in. Now I could have reacted badly, and that thing could have got worse. But instead, I took a moment and thought, you know what? He's really hurting right now. He's really upset about grandmama. So what I did was, I didn't let my voice quaver or quake. I said, hey, buddy, I'm going to take care of grandma. Okay, you guys, let's help load her up. They're looking at me like I'm crazy. And I'm winking like, we need to get out of here before we get shot up in this place. You know what I'm saying? So we worked grandma for him because he was the patient. Plus, it was safer to get out of there than just sit around a little bit. I see some chat bubbles have popped up. Let's see what we got. Oh, I'm here at work with no sound, so if you're talking to me, I cannot hear you. Sorry. Hey, no problemo. So we've talked about community paramedicine and mobile integrated healthcare teams. That might be the best example of the team concept of continuum of care. So this concept of community paramedicine, it's only been around a couple of years, but EMS is one of the last professions in healthcare that makes house calls. Back in the day, if you had something going on, you would call your doctor and he'd show up to your house. Hey, what's up? How you doing? How's mom and them? And nowadays you go to them and you have to have a preferred provider and all this other stuff. But EMS still comes, regardless if you got insurance, regardless if you can pay or not, we're still going to show up and do our job. And as a EMT or a paramedic, it's not your job to really get too involved in that ambulance bill stuff. You treat the patient, and there are whole teams of people that work in your organization. I promise their job is to get that bill paid. Now, you want to do your part, of course, to get it to, if you can, get the billing information and help out your company or organization. It's not because we won't make a big paycheck. I get nothing from it, but if my organization gets paid, they can pay my paycheck. They can buy nice equipment for me to use. I mean, it's just a trickle down effect. So mobile integrated healthcare is where we go and still see these patients at the place that they're at home. As you may not know, not everything has to go to the ER lickety split. Matter of fact, I'd say 80, sometimes 90% of the people that call us don't really need an ER. But Josh, what do you mean? I mean, an emergency room is for the dead and dying. Urgent care is for the sick and uncomfortable. But how can we differentiate in EMS a lot of times what's going on? I get called for weakness, and this old lady's like, I just don't feel right, baby. And I put her on a 12 lead because I 12 lead everybody because I'm thorough. And there it is, lo and behold, an ST elevation myocardial infarction. She's having a heart attack, folks. And if I had just been, disregarding her and not, being thorough, I wouldn't have found or seen that she was having a heart attack. Because some patients present differently. There's always that atypical presentation. A lot of diabetics, a lot of elderly women present differently, and sometimes in acute coronary syndrome. So we have to be thorough with every patient. But not everything really needs to go to an ER. That's where this mobile integrated healthcare paramedicine, community paramedicine thing would kick in. We would have people that would show up at your house and treat you right there. They could Skype a doctor, and through the doctor, they could write you a prescription or whatever they needed to do to help you right there on scene. But that would save us tying up an ambulance. I can tell you right now, oh my Lord, I seen a picture yesterday of like Columbus, Georgia. There was a hospital that had like 15, 20 ambulances in their lot, in their ER bay, and they were full up. And there's people holding the walls for hours. And it's partly due to the pandemic, but this is not a new thing. We have had a shortage of healthcare workers in the pre-hospital setting for years now, and without good retention rates and without, retention strategies and longevity for our providers when it comes to compensation for their hours, their time, retirement, it's hard to keep people in this business. EMS has long been a labor of love, and I do love it, and I love my people. That's why I work 3 jobs myself to provide for my family. Could I go do something else? Yes. But would I be happy? No. So I do this because I do love and care about people. I am a healer. It's what I want to do. So it would be nice, though, if some of these calls that we're tying up our ambulances or tying up our ER could be treated on scene at home without having to tie up the ambulance or the ER. A lot of our frequent flyers that just need maybe some medical coaching, because sometimes that's all it is. You get on scene and you get to talk to the patient about, Miss Smith, you should really just take this medicine. This is what your doctor has written down. The blue pill today. You want to help line these up for you? I'm going to put them in order for you, okay? I'm going to write it all down so it's easy for you. Sometimes EMS is not about cardioverting and shocking, defibrillating, CPR and saving lives and stuff. It's being there for the patient and the people that need us. I had a call in Atlanta, and I've told some of you about this, but just to put it back out there, we get there and the guy has not pooped all day. His home health care nurse called out, and he is paralyzed from the waist down. And he's like in this almost rundown shack of an apartment. The windows are busted out. I'm amazed that he's living alone, and I may or may not have reported some neglect and tried to get him some help out there. But my partner's in there is really pretty much cussing the guy out for calling 911 and not being like dying. And I told my partner to wait outside. I got this. You don't need to talk to him like that. I helped the guy on the pot, let him use the restroom. I helped clean him up, and then we let him run some water, give himself a whole bath. Not bath, bath. BAFF. Whole bath. So we got him cleaned up, and I put him back in bed. And I hope that one day, if I was in that situation, somebody would care enough to do that for me. So it ain't your job to lecture patients on scene about what they call 911 for. You're called for a need, you meet the need. If he just needs that, then do that for him. Sometimes I get called for lift assists. When I worked in Americus, Georgia, there was a super sweet old couple. They were both in their 90s, and they lived alone together. Now they had little handrails all in their house and stuff, and it's like they took turns falling. Like this night, and it was a couple nights a week. This night it was the guy. Other night it's Meemaw, and another night it's Pawpaw. So they just seemed to take turns, and then the other one was like, "Yeah, he done fell again." So we'd go and help him up. We'd crack jokes with him and just make sure they was okay. And of course we would inquire about their children to check on them and stuff. And eventually they did get put into a nursing home together because they just couldn't live alone anymore. Not only were they falling, but they started getting hurt. Used to be they'd fall all the time with just a little lift assist, but eventually they got hurt. But the point of all that is that we have to think about strategies for being more effective, especially during a global pandemic, especially when we have ER wait times of 4 hours or more. We may have to get a little bit more creative out here. So what about regular teams? So regular teams that we're talking about consist of EMTs and a paramedic, or the logistics of it could be really any way your company wants to run it. Traditionally, in my mind, it was always a paramedic, and in the beginning of my career, an EMTI. Secondly, it would sometimes be an EMTA and a paramedic, or an EMTA and an EMTI, or an EMTA and an EMT B. It used to be that in the state of Georgia, EMT Bs could not work on the same ambulance together because they cannot even start an IV. There are certain things they can't do. But I'm starting to gravitate more towards we're getting to the point where imagine the day where you call 911 and nobody shows up. That'd be a very sad and very bad day for a lot of people involved. So with that going on, a lot of services around here are starting to allow EMT Bs to work together just because staffing is so bad. Primarily, you would desire a paramedic and a higher level EMT with skills and knowledge of how to do certain things and the skill set to help. But half of nothing is always going to be nothing. Half of something, do something. So that's something we need to talk about, and something that we need to make sure that we're being aware of. Some of us are getting pretty ticked off here in Georgia about the proposal of allowing an EMR provider on the 911 ambulance, or maybe allowing an EMR provider on an ambulance at all. My question is, if it's your loved one and you call an ambulance and this is all they got, would you prefer someone to show up or no one? So EMTs react to the same partner or teammate. Sometimes that's true. And hopefully you'll have the same partner. With working with the same partner, you build a continuity. My partner at Grady was fantastic EMT. I could hold out my hand and we have an airway management problem I have to fix. And my hand is placed like say a 7.5 intubation tube and a Mac 3 or 4. He knew what I wanted. He just popped it in my hand. We had that kind of relationship. We could run a call and not even talk. So with that going on, you have an amazing ability to be very effective if you work together. So temporary teams, what does that say to you? Well, that means you got a new partner every day. This is why it's a good thing to be full-time versus part-time somewhere, because if you're part-time, boy, it's a Russian roulette. You get a partner that sucks. What I did when I worked part-time somewhere, I'd just call my buddy that worked, and like, hey, you want to pick up a shift together? That way I know I had a good partner. When you have a good partner, it gives you confidence and strength and ability to perform really well. About special teams. We have special teams in the pre-hospital: fire team, rescue team, hazmat team, tactical EMS team, special event team, EMS bike team, in-hospital patient care techs, and MIH techs. So to break these down really quick, you can specialize in EMS. I chose the critical care and flight medic route. I became a CCPC. My number was number 580. Mr. Larry was actually my critical care instructor. I went ahead and took the flight medic exam as well. And I did some fixed wing for a little while, but you have to be a certain size to do the rotary wing. And I just have never met that criteria. I like food too much. I'm proud of it. But there's a lot of really cool teams you get involved in. You can get involved in fire, paramedic stuff, rescue teams. I know some of you might have been really interested in that search and rescue stuff out there out west. And that is a very fun and really cool thing to get into. I mean, it's just like, you're such a cool dude if you're just hanging out of a helicopter trying to pick people off the mountainside. That's pretty cool. Hazmat, I never really liked that a whole lot. Hazardous materials. What it means is like there's a glowing vat of toxic waste and you have to put on this like Monsters Inc. looking suit, and you're the guy they call for that. And that's cool if you like that, you know, if that's interesting to you. I never was a big fan of that. Now, tactical EMS is something we do a lot in the city of Atlanta for obvious reasons. Tactical EMS is like your SWAT medics or your medics that are trained with a little bit more of police and more militarized style training. So there's courses you can take for that, and they are fantastic. We just had the group from Austin, Texas, come to Atlanta Fire this last week and teach a kind of a TAC medic course. And I couldn't attend because I have a lot of work to do finishing off my paramedic class, but just to hear the guys that were taking it and stuff, they really enjoyed it, and they just had such a great time. And it is a fun form of EMS to do. Now, special events, I always thought was great because, like, let's say you're a Braves fan and you want to go be a special event medic, which means I want to go watch the Braves game. If anybody does get hurt during the event, I will treat them, but it's a really cool free way to go watch some sporting events. We have in the city of Atlanta, we have UFC events, Falcons games, Braves games, soccer games, all kinds of stuff, you know, concert events. It's just a really fun way to make some good money, but also a way to get to, have a, different, different thing than just running on ambulance. EMS bike team would probably kill me, but some of you might enjoy that. For me, cardio is like cheating on your wife. It's just a no-no. It's just the devil. Go lift weights, protein shakes, they'll get you dates. That's my way of thinking. But there is an EMS bike team at Hartsfield down here in Atlanta, and that's what they do. They respond on bikes. And that Grady has a bike team too. During special events, you can get on your little bike and pedal and go help people. And you're doing first responder, first aid stuff. But again, the faster we can get people to you, the better outcome you could possibly have. In hospital patient care techs, so you would be a code team. So in EMS, our bread and butter is supposed to be resuscitation, CPR, ACLS, that kind of stuff. And a lot of times hospitals will hire us just to do that kind of stuff. I mean, of course, you'll be doing other things, but that's kind of the main crux of what you're hired for. If I remember, Shepherd Spinal Center here in Atlanta hires a lot of EMTs and paramedics to work their code team. And then we got MIH technicians, which is mobile integrated healthcare. It's again when you respond in like a SUV. It can be an EMT and a paramedic. It can be an EMT and a nurse practitioner or a PA. They respond to these people's homes and treat them right where they're at. Fantastic stuff. Other non-traditional routes for EMS that you can go into are, I wouldn't advise it right now, but you used to get some really good overseas contracts. And if you did that, there was a lot of big money in that. We had a couple guys here from Central go and do that. And they would do it about 6 months out of the year, go over there, make about 150,000 and come back tax-free. That's an option. I wouldn't suggest it right now, but it's always an option. Oil rigs. You can go get an oil rig job. You can go get a job in a urgent care. I mean, the world is really your oyster. Once you're certified as an EMT and a paramedic, there is a ton of opportunity, and you will always have a job. There are always going to be sick people out there. So the world is your oyster. So a group versus a team. Let's talk about it. A group consists of individual healthcare providers working independently to help the patient. So that means somebody's triaging, treating, and transporting. This is more of the MCI style. MCI style is we kind of all break off and we all know our job and what we're supposed to do. And this is a way we can cover a lot more ground a lot quicker. That's what we're talking about when we're talking about a group. A team is a group of healthcare providers who are assigned specific roles and are working interdependently. That means we work with each other in a coordinated manner under a designated leader. So this was a more common form of EMS that on calls you'll run. The first one would have been more common on a mass casualty incident. Let's say like the Boston Marathon bomber. We would have to get into an MCI or a mass casualty type of mode really quick. Again, mass casualties, after 9/11, we found out that, hey, we all have all these crazy 10 codes and we can't talk and work well together. It became part of standard curriculum that we have. NIMS training, which is National Incident Management. And we all, when we get together in a big mass casualty type of thing, we can all snap onto the same page and be following the same directions and doing the same things. Now, again, most of the time when we are working in EMS, it's just a team effort, right? So we all have our specific roles and we work interdependently in a coordinated manner under a designated leader. Who is that leader, you may ask? Whoever has the highest medical license on scene. That is usually your paramedic. Now, what if there's a paramedic on the fire truck and the ambulance? The transport paramedic will decide what goes. Now, I am definitely going to take his advice and bounce ideas off of him and use him to help me have a great outcome. But we have to have clear roles and expectations and responsibilities. The fire department job, their main job is putting out house fires, and there are usually all EMTs or a paramedic or two spotted in there. Their job is to help us with the call. Now, a lot of firemen don't like hearing this, but I don't care. I can tell you, at least in the city of Atlanta and pretty much every city I've ever worked in, 90% of a fire department's call volume is medical calls. They don't run that many fire calls. It is the medical calls that justify them having a paid fire department. Now, fire guys don't like hearing that, but it's a fact. It is a true blue fact. Y'all don't have enough fire calls to justify having you know, a couple $1 million budget and all these fancy tools and equipment. So just throwing some facts out there, bruh. But we do need you. We do love you. This is not a slight to you at all, but I'm just giving you facts and figures. Now, with their help, I have had and ran some very successful scenes, but it's not one or the other. You don't have to pick if you're a fire guy. You can be both. Be great at both of your jobs, you know, firefighter and EMT or paramedic, and use them to your benefit, guys, when you have them on scene. Please do not treat the firemen like they're bag boys. Don't ask them to do something you yourself wouldn't be willing to do. That's free advice. You'll have a lot smoother running scenes if you do that. What about your police officers? Police officers can help. They can pump a chest. They can hold pressure on a wound. They can also help direct traffic. They can help make sure nobody crashes into us on the side of the road. They can help mitigate some combative, hostile patient circumstances. So there's a lot of stuff going on there that they can do and will be useful for. So 5 essential elements of a group: a common goal, an image of themselves as a group, a sense of continuity, a set of shared values, and different roles within the group. We all have to have clear roles and expectations. What does that mean? We can't all be chief of this, let's say we're working a code. We can't all be the guy pressing the chest. We can't all be the guy shocking. We can't all be the guy drawing meds up. Everybody has to have a place for this to work successfully. We are links in a chain, and we have to know that job and know the jobs of everybody around us. What if the guy doing compressions, he's tired? Dang, ooh. Doing compressions is a lot of work. It will wear you out. So the guy doing compressions, he may need a break. So you need to know how to do compressions. So when you're taking a break, you should probably take over airway or something else like that. You need to know all the roles in your group. So dependent groups, each individual is told what to do, how to do it by his or her supervisor. You're very micromanaged. Independent groups, each individual is responsible for his or her own area. And interdependent, everyone works together with shared responsibilities, accountability, and a common goal. Now, it is the assumption, but not fact, that when you become an EMT, that you've got it all together. You can go out there and run EMS calls, stuff like that. While that's the assumption, it's far from the truth. We're preparing you to take the National Register and be the best street EMT you can be. However, there are things I cannot teach you. Only the streets can teach you these things. I did not learn how to be aggressive with sedation until I got punched in the mouth. Boom, ow. I've got some heat on that one. Hands. So now I'm more aggressive with sedation. There are certain things I cannot teach you. You're gonna have to learn how to manage the scene and talk to people with respect and modulate your voice and tone in the way you say things, being aware of your body language and how you are approaching patients and people and the other people you're working with. If I show up and I look like a douchebag and I'm kicking off the fire crew and he does something to make me mad, I have got to control my temper, my emotions, and again, would be an objective crew member here. I'm there as an objective observer to treat the patient as an objective provider. So we want a shared goal, clear roles and responsibilities. I cannot stress that one enough to you. Be very clear about what you want done. Again, communication is not key. Comprehension is key. If I say I'm going to lacerate, this patient's lacerated on the, I don't know, medial anterior portion of the vastus lateralis. Some of you might know what that means, but some of you won't. But if I say, hey, this guy's got a cut on the front of his leg over there, then you'd be like, oh, yeah, I should probably work on that and hold pressure so he don't bleed that. You got it, fam. You got it. So again, communication is not key. It is not comprehension. Make sure you're talking so people can understand you. Talk slow and make sure everybody knows what they're supposed to do. Hey, you, Zarina, I need you to do this. Thank you. Hey, Carly, hand me that right there, please, and thank you. So I got to be very clear with what I want done. Diverse and competent skill sets. Not all EMTs and not all paramedics are created equally. Not all firefighters or police officers are created equally. I've learned in life that what you put in is what you get out. And I explained to you guys early on, this is not art appreciation or something like that. Not that art appreciation ain't is not important, but the stakes of life and death are not, as a parent, if in my appreciation of art versus, how to remember how to do a tourniquet. It could be life or death, literally. So my advice to you is to be very competent in your skill set and your scope of practice. Knowing also how to be a very effective teammate, to me, the paramedic would be very, very vital to your success. I would want to work with people who are competent, and I want to work with people who know what they're doing. And I have no problem helping you and showing you on the truck. That's how we learn. We have a problem in EMS and fire and police, healthcare, nursing. We eat our young. How do you not know this? You just stupid or something? No, it's my first day. And you have to remember where you came from, sir. So be open ears, ask questions. There's no such thing as a stupid question. Please, nobody go and try and prove me wrong. But if at some point I never asked something, I would not know it either. Effective collaboration and communication, and supportive and coordinated leadership. There's a lot to be said about leadership. That is a whole lecture in itself. But you need effective and strong leaders. At the beginning of your career, you should have displayed at least a minimal competency to operate safely as an EMT. As time and years go by, you develop, a strong foundational competency where you've really got this stuff on lock, and then eventual mastery. Whoever your leader is should be a master of what they do. Supporting you because they know where you're coming from. They have sat in your seat. They know what you need to be successful, and they're giving it to you. They're filtering between administration and you and making sure that we're achieving operational goals, but also accommodating their people. So if I can achieve both, why would I not? Supportive and coordinated leadership. Your leader should be a master of their craft. They should know the laws, the bylaws, the nuances, the SOPs by like the back of their hand. They should be an invaluable resource for you. The problem is in EMS, we sometimes think because somebody's a good paramedic, they will be a good supervisor. I was made a supervisor of a multi-million-dollar company at like 26 years old. I'd been a paramedic for 6 years, and I think part of the reason I was promoted was because I showed up to work on time and I had a lot of integrity and morals. That doesn't mean I was going to be a good supervisor, and there was no class, there was no prep, and that's how a lot of this goes in EMS. We just thrown to the wolves, and you had to figure some stuff out really quick. And I ain't gonna lie, there was a couple times I called the company nurse at 3 a.m. and thank God she answered, like, hey, what do I do about this here? Better tell me if the place gonna burn down. And that's what happened. Over the years, I developed experience. There's two ways to learn things. Experience is me touching the hot stove and getting burned. Wisdom is you watching me touch the hot stove and not putting your hand on it too. So the communication and team dynamics fostered for crew resource management and team situational awareness. So that's a mouthful. So let's just break it down. Communication and team dynamics, how we work together as a unit, fostered with crew resource management. As a crew resources, we need to know who the paramedic is, what their skill set is. You're the EMT B. We need to know what everybody can do, how many years they have in. All these things could make a difference. I wouldn't want to put somebody who's brand spanking new back there when I've got an old chap in the front that instead of driving, he can get back there and help me. But then again, if I didn't, you would never learn it. So there's a nuance to that as well, small little details to this. So knowing what resource we have and how to use them appropriately is appropriate, as appropriately as possible is a fantastic skill set. What about team situational awareness? I will say this, I get on to people sometimes about situational awareness because it can change on a dime. It can change super quick. The scene was safe, but now it's not. So always scanning, your head is on a swivel. You're always checking things out, evaluating, reevaluating, then reevaluating every few minutes because it can change in seconds. The scene was safe, but now it is not. So they recommend the PACE mnemonic: probe, alert, challenge, emergency. probe, alert, challenge, emergency. What about transferring of patient care? For those of you that are watching live, if you have any questions as we go through, please feel free to speak up. So when I transfer care to somebody, I want to make sure that it is a smooth transfer, that they have all the information they need to continue care with the patient. So general guidelines are uninterrupted critical care. If I've got my pacer pads on there, we're going to leave them on there until you can take over. Minimal interference, not a whole lot of extra hands in there. We got exactly what we need to make these things happen. Respectful interaction. Now that, ooh, let me tell you, respectful interaction is sometimes hard when you're trying to give report to a nurse and she's kind of just blowing you off and she's being a real douchebag and you're having to remain professional. And that is hard sometimes. I don't know what she's been through for her whole shift. I know I've been getting my teeth kicked in for the last 12 hours and it does suck because I've been up here 4 times. She's tired of seeing me, but I have the best snack room. I'm sorry. / the patient requested to be here. Sometimes it is hard to do that, but I can't control what others do. But as for me and my house, we are going to do what is right. We're going to be legal, moral, ethical, and respectful and professional to everyone. Again, would it really do the patient any good for me to blow my gasket on this nurse right here and call her a big douchebag? It'd make me feel better, yes. But no, it would not help the patient. What if the fire guy on scene ticks me off by doing something stupid? Would it really help the patient for me to blow up on him right then? No. So it presents me with an opportunity to handle this like a professional adult. Hey, fire guy, come here, buddy. Let me talk to you. So I appreciate what you were doing there, but I really feel like if we do it this way next time, we can have a better outcome, and that this is how I like to see things done. And here's why. Based on the studies provided by the new EMS updated guidelines, blah, blah, and give them reasons. Don't just do it because it's your opinion. You know, you need to have a reason for the season, why you're doing certain things. Don't just do it because it's the way I was taught. Man, it made me so mad. One of my students came to me the other day, was like, I was riding at this service over here, and this medic was mad at me because I put on the electrodes a certain way. I was like, which way did you put them on? Well, the way you told me. I was like, well, the way I told you is the 2020 updated ACLS guidelines, and they're a recommended way of doing it. Well, she didn't like that. She said she was taught this way. I was like, how long has she been doing it? Oh, 20-something years, and she ain't updated since then. So again, it is hard sometimes to be respectful, but again, you represent me, you represent Mr. Larry, you need to be respectful and professional. Your professional reputation will go farther than you could ever dream possible. People will know about you. We have a small community in EMS and fire and police. And if you're a big dingleberry, everybody will know that you're a big dingleberry and you're disrespectful, and nobody will want to work with you, and you will not find it easy to find employment. So be respectful. We need to have common priorities and a common language or system. Again, just use plain talk. Don't try and get fancy. Just because I know medical terms this big don't mean I need to use them. Doesn't create a lot of continuity on scene. That creates chaos if nobody knows what I'm saying. So the communication and team dynamics fostered from crew resource management, and that is exactly what sorry. So here's a fun fact. BLS and ALS cannot exist without the other. Wait. BLS and ALS do work best together. I will say that. BLS should become before ALS. The simple things work. If I can do something simply without having to get all invasive, because sometimes when paramedics get invasive, it can hurt a patient. Let's say a patient that has an extremely fast heart rate. We'll call it SVT, supraventricular tachycardia. Now, for this EMT class, that won't make sense to you, but let's just say their heart rate is way too fast. I can either A, ask them to vagal down, or B, cardiovert them, where I'm going to electrocute them until they slow their heart rate down. Which one do you think will hurt less? You're right. Vagaling down by asking them, hey, I want you to push out like you got a fart. I'm serious. It will release acetylcholine and it will slow down their heart rate. Sometimes it will convert their heart rate to a normal heart rate or a lot slower one that's safer for them. So again, is it safer and less invasive and less painful for me to either A, ask them to fart, or B, electrocute them? Let's weigh that one. Yes, farting. So we need each other. Now, what if I got tunnel vision? Oh, it's an SVT, I'm gonna shock you. But then my partner's like, maybe we should try some bagels first. Oh, you know what, you're right. Let's try that first. There are other bagels besides that one too. We'll learn that later, but you don't just have to do that one. So BLS efforts must continue through the continuum of care. If you do nothing else, BLS efforts have to continue. Something as simple as putting a patient on oxygen or performing CPR, they're the ones that have to continue. What may be a paramedic only skill in your EMS system may be common for an EMT performing another. That all goes down to scope of practice and your protocols. Zarina, what does that mean? All right, I'm gonna assume you're busy. So what does that mean? Let's say even in the state of Georgia, if I go work at Jackson County EMS, I have a set of protocols that are saying what I can do as a paramedic. And let's say I go work at Grady, I have another set of protocols. Each of these protocols are approved by the medical director of that EMS service. So I can only do what they have written down. Now, is there some flexibility? Is there some bending? Is there me reading between the black and white of those protocols sometimes and working in the gray? Yes, that is very possible. I can operate in the gray sometimes. It doesn't mean I can practice medicine without a license, but it does mean that there are some gray areas that I can critically think in. If I really need help, I can call med control and get permission to do something that's outside of my protocols. As long as they tell me I can do it, I'm good. So assisting with ALS skills. One of the best things you can do for me as a paramedic is help me do my job by making me do it better. So patient preparation. If you help me, if you prep the patient for the skills and stuff I need done, that's a great service you've done me, and it's also making what I'm doing quicker. Equipment, as I said, my Grady partner, I could hold out my hand and he would place in it the stuff I needed to be successful. He knew my preferences, he knew what I wanted. Actually performing the procedure. There are procedures that you, the EMT B, can do, and there are procedures you can assist me in doing, and then continuing care. If I say, hey, buddy, can you bag this patient for me 1 second while I just grab this drug? You can continue the care for me. So critical thinking and making decisions in EMS. Critical thinking, that is thinking through a problem and finding the best solution that causes no harm and provides the patient with the best outcome. Remember, you are a patient advocate. Every decision you make should be to minimize their pain and suffering and to make sure they have the best outcome possible. The level of your care, how do I put this? The quality of your care will affect the quality of their life. Ooh, I like that. Somebody quote me. The quality of your care will affect the quality of their life. I like it. So what am I saying there? How good you do your job could affect whether they live or die, but also what if they survive and now they got this, they're disabled because of how poorly you did your job. So it really could affect the quality of their life or lack thereof. So again, this ain't art appreciation class 101. This is EMT 101. I need you to pour everything you got into this. Everything else is on the back burner. I asked you that night one, put everything else on the back burner. Of course, your family comes first. I'm not saying that because mine does as well. But I need you to pour everything you got into this. Study and work hard. So effective decisions are based on sound, up-to-date knowledge. I need to be gathering information. As soon as I hear the dispatch, I am gathering information. Does that not mean that dispatch could be wrong? They could be, but they're only operating off of what they were told. They gave me what they had. No reason to be mad at them. Unless you just want to be, because it's fun. I agree with that. So sound up-to-date knowledge. What is going on? What am I called for? The information provided by the patient. Now, sometimes patients can make it really cut and dry. I fell off this thing. I hurt my foot. Now it hurts really bad. Okay. Looks broken to me because it's twisted in the question mark. So there's that. So it makes it pretty easy when you can talk to the patient. They can tell you exactly what's going on. Now, sometimes they don't know what's going on. So that's why we got to get a history. So the patient's history would tell me, like, do they have heart problems? Do they take medications for this? No wonder she's over there and she's unresponsive. She took her insulin and didn't eat, so now she's unresponsive. So the history of the patient can tell me a lot. And then the physical examination. Every patient that you pick up should get a physical examination, even your medical patients. This is how you find fentanyl patches and the patient's passed out. This is how you find insulin pumps. This is how you find open wounds and the patient's really hot to the touch and they're really sick and their temperature's up and they're septic. This is how you find these type of things, by being as thorough as possible, head to toe, systematically assessing your patient. That's how you are a good provider. So, stages of the decision-making process. Pre-arrival. If I'm called to a pediatric seizure, I know the dose for the drug I would give to stop the seizing. But I'm still going to pull out the playbook, look through it, and be 150% sure. I want you to learn how to measure twice and cut once. Measure twice and cut once. That means that you are being double, triple sure that you're doing the right thing for your patient. So there is a decision-making process in the pre-arrival. Let's say it is, I'm going to this type of call, I'm pre-gaming in my head. Let's say I'm going to this section of town, I'm putting body armor on. Let's say I'm going to this specific address that has a wonky driveway. Okay, I know how to park the ambulance in a special way. Arrival, we get there, we arrive, we make a plan on how to get to the patient. During the call, I'm making decisions based on the things I see, by surveying my scene, by looking around me and finding things to help me, things to get out my way. I'm not above asking people to help. Hey, can you just grab that and help me not let her fall? Thanks, buddy. You're a good son to her. And then after the call, I like to do a debrief after my call, especially if it was a really bad one. Me and my partner would sit there for a minute and talk about it. Hey man, you all right? Yeah, I need a drink though. Well, after work we can talk about it, but right now, no. So after the call, having a call breakdown is a very good idea to talk about the things you did right, things you did wrong, things that you wish you'd have done better. But I wouldn't sit there and second guess myself to death. All the what ifs could drive you crazy. But if you see an area of improvement and having that a good partner, that's an accountability partner, not only is he your partner on the truck, but your partner can hold you accountable, it's worth its weight in gold. You know, my partner might say to me, hey, Josh, you got the two, but you got it faster if you use the bougie first. Well, you're right. I should have listened to you, but I was in my moment, but next time I will, buddy. I appreciate you stepping up for me like that. Also, you having the humility to take criticism. But I'm a super EMT of the year, blah, blah, blah. Well, we all have room for improvement. Nobody's 100% all the time. We all make mistakes and goof up. So my advice is to be humble and take criticism. You can learn from anybody. Even though I am your instructor, you could probably teach me some things. No doubt. There are things that you can do that can teach me something, I'm sure. So be open and humble. So decision traps. Ooh. Bias. Bias would be allowing yourself to be more subjective than necessary. So what does that mean? Subjective. So subjective means that I'm allowing my own thoughts and feelings and personal ideas come into play. What about anchoring? Anchoring. So that would be a form of cognitive bias where your decisions are influenced by a particular reference point or an anchor. Like, we don't have to get so caught up in dogma that, well, he said this, so we got to do it this way, but he has nothing showing the signs and symptoms that mean he's actually having this emergency go on. So it basically means don't get caught so much into one thing that was said or one thing that you saw and not allow for other possibilities to be possible. And then overconfidence. Well, I've been overconfident before and I've ended up looking silly because I was 100% sure this was going on and then I was wrong and then I looked silly. Learn from me. Don't be overconfident. Allow yourself to be wrong. You know what? You're right. I could be wrong. It's a possibility. So let's just be thorough and check everything out. Let's do a full head to toe. Let's do all vitals. Let's perform a 12 lead. Let's check a blood sugar. Let's do all these things and be 100% sure as far as we can be in the pre-hospital setting. These are 3 good ones. So team conflicts. Let's talk about it. The patient comes first. I've already kind of said that. It ain't about you, player. It doesn't matter what patch you wear. I used to hate. This still happens to this day. We'd be working in the city of Atlanta, and whether you're Grady or Atlanta Fire, the patient don't care what patch you wear. Man, they just want a good outcome. They just want to live or have and be able to walk and hug their grandchildren and go back to work and whatever else. The patient comes first. Nobody cares how many years you've been a firefighter. Nobody cares how awesome you are as a Grady medic. Nobody cares that you work at this little tiny 911 up there above Roswell and Alpharetta, and you in that you think you're really super great at EMS. Nobody cares. The patient comes first, bro. And if you can be the best paramedic in the world, but if you're not compassionate and if you're not kind, nobody gives a crap how good at your job you are. And that's the facts. Learn compassion first. Your patient comes first. Put them first. Fight for your patients. Don't let anybody hurt them, come between them, and put them first. Do not engage. I like this one. Do not engage is a good one. It is a simple one of just don't pick the fight right then and there. So do not engage your patient. Well, do not engage somebody on scene. What if this fireman just ticks you off and you punch him in the mouth? Don't do it. Resist the urge. What about your partner? Again, I've worked 24-hour shifts with people I did not like. I still treated them with respect and I still treated them appropriately. What about keeping your cool? God, that's hard. I have been a victim of emotionalism a few times. Let's say like a possible child abuse case, and I'm over there and seething. But if I blow up, I'm going to make things worse for the child. I'll alert them that I'm on to them, and I might ruin the child's case somehow. So what if you got a problem child on the scene? Separate that person from the issue. Hey, buddy, I know you just want to help, but I need you to come stand over here and direct traffic or do whatever. Get them out of the scene. I had to do that. I've done it for a couple of times, but the one I'm thinking of that pops in my mind was this fireman was tired and they were burned out. He's burned out, man. He'd been doing this 25 years, man. And he was like actually the captain of that station that responded. And he was pissed off that this patient had called for something that wasn't exactly life-threatening. He was just giving them the business. And I had to stand up for my patient. Also, he was just stirring the pot. He ain't the one going to be alone in the back of this box with this person that he's pissed off. If they get combative back there when it's just me, that's a problem for me. Also for my patient's anxiety and blah, blah, blah. I said, hey, buddy, let you and me come on outside now. Hey, I know, I get it, but this ain't the time, the place. I know she pissed you off. I get it. But again, you ain't got to be back there alone with her. She's going to go anyway. If it ain't us, it'll be somebody else. She's going to call again. So we're going to transport her. Go wait in the truck. You guys can actually cut loose. I don't need you. Cut loose. So also choosing your battles, that goes for a lot of things. If some of you are not married, ooh, loaded. If you're not married, let me give you some advice. Choose your battles. There are certain hills that you need to choose. I mean, you got to choose your hill to die on, basically. Like, is this really something I want to fight tooth and nail for? Or is it really not that important? Now, me personally, I think you should always choose those battles and choose them to be is it really mattering right now? If I choose a battle, it's usually for patients, advocacy, or crew safety. Some I remember calling the supervisor and I was working that night and it was steaming. It was like swamp booty weather. It was hot as hell outside. And as you know, in the city of Atlanta, when it gets that hot, everybody's shooting everybody and you are busy. The call volume in the summer picks up tremendously. So our air conditioning quit working. We're like going, running call after call. And I called my supervisor. I said, hey man, we got to come out this truck. He's like, what do you mean? I'm like, AC's out, man. I'm sweating bullets over here and we can't transport patients. And I know I didn't have to, but I wanted to make sure that I was getting my point across, And I was like, hey, as a paramedic instructor, one of the first things we teach our guys is that we got to be able to control the environment and put them in a cold environment. And I just went on to explain also the legality of it. I mean, he got it, but I'm making sure I picked this battle. And it was one that was a hill I was willing to die on. We can go to the state office if you want to. He was a cool guy and he got it, but he was just a little bit amped up because we were all so busy. But I just had to lay it out for him. It's illegal. I can't treat patients for heat emergencies back here. I myself am starting to dehydrate. There's a lot of stuff going into that, a lot of nuances. And the supervisors in the city of Atlanta, they're pretty fantastic. And there wasn't much of a battle there, but it's one I would die on. I'm not going to sit here and melt in the back of this hot swamp booty ambulance for the next 10 hours. I'm sorry. My partner won't do it, and I won't put my patients through it either. So choosing your battles is vitally important, and knowing how to fight those battles. Sometimes it ain't you that needs to fight them. You know what? You messed up bad on scene. So guess what? This is going to be between you and your medical director. It sounds like you need some remediation. I ain't got to tell him that. I can write an incident report, give it to my supervisor, and those white shirts can talk to white shirts and they can deal with it. So, quick review. How'd that go with everybody? So, in a nutshell, we are coming back down to the team approach. What I want you to take from this tonight is this. It is not about you. Not about you, not about you. It is about your patient, and the quality of your care will affect the quality of their life. Put them first. Leave your ego at home. Okay? Leave your ego at home. Leave your pride at home. Be humble. Take criticism. Does that mean you can criticize me? What if I decide to pick up a shift and you are my partner? If you see me doing something stupid, please let me know. If I got a booger hanging, let me know. It is okay. We should all have such an attitude where we can be coachable and teachable and moldable. I don't care what your background was before. You could have been whatever. But we should all be teachable, all be moldable. So that concludes actually chapter 9 of our book. We're still going to have to read through it and get other things from it. And I'm still going to test you over a lot of it. But that is the crux of what we're doing. We're going to do chapter 10 here tonight as well. We're going to take a short commercial break, and I'm going to send out a new link, and we can all jump back on that one. So let's say it is 6:20 now. Let's come back at 6:40, and I will send out the new link, and we will